going forward. Also, we special welcome to viewers from YouTube and LinkedIn as well. Today, we're going to have a talk from Dr. Ijeoma Chibuzo. Ijeoma is a consultant urologist and a very special one at that. She is the first and only fellow in urology of the National Postgraduate Medical Council of Nigeria. She's committed, according to her bio, to education and research. So that is what we're going to get this morning. Lots of education based and founded on research. Ijeoma is a very special lady. I've only ever met one other person who, if you had to write to them and you had to put all their degrees, you would probably end up writing to the back of the envelope. So we've got a very special presenter this morning, and I would encourage you to listen carefully and to ask any questions that you have at the end. This talk, I'm told, will be restricted to women's health, but I suppose Ijeoma would be able to look at other areas that you may be interested in as well. I think that's enough about myself and Ijeoma. Maybe we should delve into the proper meat of the morning. Ijeoma, welcome. Thank you very much for coming, and over to you.
Thank you for having me. I'm delighted to be here. And thank you for the warm introduction. Is it all right if I share my screen then?
Yes, it is.
Okay. So as Dr. Sapong mentioned, we shall be talking about urinary incontinence today. And because this is the Women's Health Month, we'll focus more on urinary incontinence in women. Of course, if you have any pressing questions and you want to cut across genders at the end, do let me know, and I hope to clear whatever doubt you have. So we're going to be managing urinary incontinence, and let's stay dry. Let's stay confident together, shall we? So urinary incontinence in our communities is talked about far less than we would like. A lot of women tend to find it more like a taboo to be able to speak about it. I remember there was this interesting paper that showed that almost 35 to 40% of women don't talk about incontinence. We have different types of incontinence, different prevalence of each one. So, and I think it was quite important to say why urinary incontinence is worse in the woman compared to the male. Why is it that you find a lot of women having near to complete emptying of their bladders compared to their male counterparts? And I try to show it in quite simplistic diagrams. These are from the Australian Continence Society. And everything is really based on what is in the pelvic floor. So this top picture is showing us the bony pelvis and then the muscles that are underneath that. And if you see the lower picture, you have holes sort of in those muscles. So those muscles are the pelvic floor. And these holes are where organs pass through. So this will be the one for the bowel. This will be the one for the female organ. So we've got the uterus and cervix here. And then this will be the one for the urethra. This is our concern for this study. So basically what we're saying is that if the muscles which hold up the pelvic floor become lax, then it means that there is less constriction preventing urine, in this case, from passing. And what are the things that can make it lax in a woman? As we grow older, it gets more lax. And that's just because the female hormone estrogen maintains that pelvic floor, helps maintain the strength. And as we get older, we lose that, so it becomes lax. Carrying a pregnancy increases the weight on that pelvic floor. So with each pregnancy, there is increased pressure on that and it can become lax. If you find, a lot of women will tell you that when they're pregnant, as they cough or laugh, they might leak urine. It's just for that reason. With childbirth, a baby has to pass through this second hole. So that means that the pelvic floor is going to get lax, and that will affect other things passing out. So some people find that they will leak from the other orifices after they have delivered a child. And this is it in a better view. So we call our pelvic floor our hammock, you know, what you lie on sometimes, and connected between trees. A lot of us with fun childhoods will remember doing that. So that support is so necessary to maintain urine from leaking out through there. But once that is lax, we lose that. The other thing that women have different from men is that there's a muscle. We call it the sphincter. In men, it's like a vice. It goes all around wrapping the urethra, which is the water channel. In women, it's quite gently disposed. It doesn't restrict urine as much. The other thing is women have a very short urethra. So it means that it has a short distance to travel before it comes out. So all these factors just increase the risk for a woman to have incontinence, just by virtue of being a woman. We've got different types. So you don't have to remember all of them, but the key is knowing what they are because they are managed differently. There are some similarities. So stress incontinence, we see this in almost 45 to 50% of women. And like I said, it increases with age. It increases with having delivered children. And this is when there is an involuntary loss of urine when we have things like coughing, sneezing, laughing. You can imagine just having a sneeze and flooding. In incontinence, urgency-related incontinence, there is an involuntary loss of urine when that person already knows they need to go to pass urine. So it's in the process of trying to get to pass urine that they leak. Sometimes we have a combination of the two, which is the mixed urinary incontinence. Sometimes some people are just wet continuously. Now, the common things, especially in sub-Saharan Africa, that can cause that in an adult woman can be related to a defect. People might have often heard of fistulae or a fistula. The most common type of fistula, which is an abnormal connection between two organs, the most common type is the connection between the bladder and the vagina. And this follows prolonged labor that is not managed adequately. Other types of continuous defects, sometimes following a surgery, there might be a connection between another set of two organs, maybe the tube that connects the kidney to the bladder, called the ureter, and the vagina. It can happen. Some people are also born with some defects that can cause continuous urinary incontinence. We call that an ectopic ureter. What that means is that where the tube that connects the kidney to the bladder, the opening doesn't open where it should. So because it's opening in a different place, it doesn't have the normal mechanisms that will stop you from leaking urine. All that muscle I talked about around the urethra, it's not there because it's not opening where it needs to open. So that's another reason why they have a continuous leak. Now, in overflow incontinence, this person is probably not emptying their bladder well. So the bladder keeps filling and eventually it trickles out. So they're more in what we call a chronic retention, but it trickles out eventually. It's like having a dam and the dam is full and it overfloods its gates eventually. Now, functional incontinence, we have to always remember that because sometimes it's not a problem with the bladder or the connections or the outlet from the bladder. Functional just means that this person has some mobility issues. So before they can get to the bathroom, they leak. That's commonly what it's used to refer to. And there are so many conditions that can limit mobility, and just based on that can cause incontinence. Having said that, some functional issues that restrict mobility also affect nerves. So they have two means by which they cause incontinence. For example, if I bring it home, someone with Parkinson's disease, they have restricted mobility, so getting to the bathroom will be an issue, but they also have nerve issues with their bladder. Bedwetting is nighttime wetting. And then this is quite important, the post-micturition dribble in a woman, because when a lady tells you that after she voids normally, then urine trickles out, you start thinking, is there a diverticulum? A diverticulum is where there's an out pouch of this urethra, but like a bulge of it here, so like a sac. And then that will trickle out and empty later. So when you hear that, think of that in a woman. Now, why is the person leaking? So I've talked about non-modifiable things. But the things that we can modify, remember we said stress urinary incontinence is when there is loss of urine when the person has increased abdominal pressure. A common thing that can cause increased abdominal pressure is if the person is obese. So that is quite common because we have a lot of gut, should I say gut fat that can be reduced, and that's putting weight on the pelvic floor. In terms of urge incontinence, which I mentioned is when the person rushes to the bathroom, some lifestyle increases that risk. For example, a lot of people take things that they don't know are bladder irritants. Coffee, that a lot of people love. Tea, lots of fizzy drinks, lots of carbonated drinks, lots of soda water. Those are all bladder irritants. So if people can stop that, then that helps with how the bladder works. Now, the bowel is quite near the bladder. So if the bowel is constantly full of feces, it means it will keep irritating the bladder. So if the person takes high fiber diets, then they empty their bowel well, and they have less bladder irritation. How does smoking cause urinary incontinence? Different means. A person who smokes is prone to chronic cough. And with chronic cough, you keep putting more pressure on the pelvic floor. So that makes it, makes them more prone to leaking. Smoking also reduces blood supply to different regions, including to the muscles. It also reduces the kind of connective tissue that makes up the pelvic floor, so it makes everything lax. Diabetes, it is modifiable because if someone controls their diabetes, then they control its bad effects on the bladder. When glucose that is poorly metabolized is broken down, it becomes sorbitol. Sorbitol in itself is a bladder irritant. Diabetes that is poorly controlled also affects the nerves, and that will affect how the bladder contracts. Or how the bladder responds to urine. So they can have urinary incontinence with that. I'm putting substance use here, and I'm really making it an issue because now a lot of the literature will tell you patients above 30, women above 30 have increased risk of urinary incontinence by virtue of what I've told you. However, nowadays you find young children, teenagers, presenting with urinary incontinence, and this is because of the widespread availability of a drug called ketamine. So now children, even from secondary school, they're able to buy it outside their classes and they snort it, and it destroys the urinary tract. And we have teenagers and young adults coming leaking urine because it has destroyed their bladders. Recurrent urinary tract infections cause irritation to the bladder, and they can have all the symptoms of urgency and incontinence. Some patients are just on drugs that are diuretics, and diuretics means that it makes you produce more urine. So that means your bladder is presented with more urine that it has to empty, and those can promote incontinence. I've mentioned how prolonged labor can increase the risk of a fistula. Prior treatment, radiotherapy itself, which is a treatment for other things, including cancers. One of the side effects is that it can make the bladder more contracted, so it holds less, and the person needs to empty their bladder more or can't control it as well. Neurological issues, some spine-related issues, or even learning disability issues can cause incontinence. I put this here because I know some of our audience will be from back home, and this is just telling you about young people who have babies early, or people who have large babies that are wider than their pelvis and they struggle getting them out. If that is the case, if a person does not have supervised pregnancy to recognize the risk, or they don't have a supervised delivery, what happens is that they struggle to try to get the baby out, and the baby puts pressure on that junction where their womb is and squeezes on the bladder here. And this is the bladder. So it's the baby's head is pressing the bladder against the pubic bone, so they can have holes in their bladder, which are the fistulae. So I always talk about prevention before cure. Can we as women take incontinence into our hands and prevent it? We've talked about the weight. The ideal BMI depends on your weight and height, and that should be 18 to 25 kilograms per meter squared. People are overweight when it's 25 to 30, but above 30, it's a no-no. You need to work to get it below 30 kilograms per meter squared when trying to battle incontinence. Pelvic floor exercise, so important. There's something everybody can do. I always tell patients that if you're thinking of, maybe you're in public and you feel wind coming on, commonly known as a fart, and you don't want it to come on, you can squeeze your pelvic muscles. It's the same muscles that you would squeeze if you're trying to stop a wee or a void. So squeezing those, nobody needs to know you're doing it. Squeezing that, holding it for 10 seconds, and then releasing, and then doing that multiple times in a day. We usually say do 8 to 10 times in the morning, 8 to 10 times in the afternoon, 8 to 10 times at night. And then follow this up by holding it and releasing suddenly. Those are pelvic floor exercises. They are easy to do. But a lot of times people say they're doing it, but they're not doing it right, because either they're tensing their abdominal muscles or doing their buttocks. But if you follow that instruction, you usually will get it right. Stop drinking late into the night, especially for the bedwetters. Stop 2 to 3 hours before you go to bed. We've talked about the healthy diet. Watch what you drink. No fizzy drinks, reduce your alcohol, because alcohol is a diuretic, and all the others. Now, when we're assessing for incontinence, we want to know, how often do you leak? Have you identified any triggers? Is it when you cough, sneeze, or is it the urge? How severe is it? How much pads are you using? Because those tell us the severity. How has it affected your quality of life? Another important thing to note is, how badly is the skin around your vulva affected, because urine is constantly in contact with it, so that causes a type of dermatitis. And what measures are you taking to protect your skin? Because all of this we can address. Another thing we have to be sure about in women is it actually urine? So we need to differentiate that it's urine and not vaginal discharge that is leaking or something else. And we need to know what your expectations are in terms of this. Since we've mentioned other things that can affect that pelvic floor, if there's a prolapse, we also need to know, because that should be treated accordingly, and just treatment of that might take care of the incontinence. So what I will emphasize that people don't do, the proverbial ostrich is said to bury their head in the sand. So don't hide away in the room saying every woman has it, I don't need to get help. Because incontinence is just a symptom. There might be something underlying. So don't stay in the room, don't struggle alone. There is help for it. Report to your GP if you're in an area that has that. Report to your doctor wherever you are. They will ask some questions, which are part of those assessments I told you about. They will give you a questionnaire. The questionnaire is to try and help us categorize the severity and what we need to do. They will look for the cause. You will be examined. Some of the examinations might be a bit intimate, but that is just to make sure there's no prolapse, make sure that there's no shrinkage or shriveling of the tissues around there, which we commonly see in menopause. Because a postmenopausal lady, if she has atrophy, it means the solution to her problem is just estrogen. So those are important. And they will also check your bowel. They also look for other causes from your chest, from your spine, whatever it is. Minimal tests will be done at the initial level in the primary care. They'll make sure your urine doesn't have infections. They'll make sure you're emptying your bladder with a scan. And sometimes if they feel your kidney function might be affected by what is going on, they might do a blood test. I put this here because some people struggle with filling this. So I thought this would be a good opportunity to talk about it when we send it out to people. We're just trying to have a better picture of what you're drinking, how much you're weeing, and how often you're weeing. So we'll ask you to buy a jug to measure your urine. It's called a bladder diary. And each time you wee, you will write down how much you passed water. If you leak, you write when you leaked and what you were doing when you leaked. And then it just helps us know what your bladder capacity is and how much you're passing out. It can also help us differentiate that some people pass a lot of urine at night. We call it, they might think it's a symptom of the urinary tract. But when we look at that chart, we can see that they're passing most of it or a third of it at nighttime. That might tell us that the whole problem is just a cardiac problem. So it's important to fill it. Now, things that we would advise initially, not everything needs to go to a secondary or tertiary center. The advice that can be given to you are just simple things. Alter what you drink, reduce the caffeine, reduce the fizzy drinks, reduce the carbonated drinks, stop smoking. If you're using any substance abuse, you're using ketamine, stop doing that. If you have things that can be corrected, maybe a chronic cough, constipation, those are the things that need to be sorted out, the pelvic floor. And when you're really struggling socially, quality of life wise, and needing to rush to bathrooms, there's something that's available under the NHS. It's called a radar key. So you can get that. So it gives you access to all the disabled bathrooms so that you're not struggling to find a bathroom when you need to. I put this here because you can find this anywhere on the internet. Your BMI, you calculate it weight for height. Try to maintain your BMI, ideally between 18 and 25 and less than 30 if you really want to control, especially stress incontinence. Now, when you've tried conservative measures, there are medication that you can be offered. And what the medication does is, because we know that incontinence can be from the pelvic floor, being weak, or it can be from the bladder if it's contracting quite a lot, then we can use medication to tackle those. And we tackle other causes. So we can relax the bladder so it doesn't keep contracting and the person doesn't lose urine. We can help relax the bladder and strengthen the sphincter to help with stress symptoms. For those who have recurrent infections and all the symptoms that go with that, we can help sort that out. If they're postmenopausal, like I said, estrogen restores the normal epithelium and helps keep infections at bay. Some people have what we call interstitial cystitis, or those who use ketamine have eroded the lining of their bladder. So sometimes things to coat the bladder lining and restore it so that it's not irritated by urine. Medication are there for that. For those who have nighttime losses, strictly, we have things that can reduce that, maybe desmopressin. It's not given commonly, but for those in whom it's indicated, yes. Now, some people want a very quick fix. It doesn't happen in days. Patience, consistency, and then you will get success. So we would advise bladder training. For those who have urge incontinence, they need to rush to the bathroom. We would say, try to keep delaying how quickly you go. So initially we'll say, void every hour on the hour, and then gradually be increasing the time between voids. And you realize that your bladder is getting retrained. Do that for at least 6 weeks. Pelvic muscle exercises, I've told you about that. Do that for at least 3 months before we get it right. And then you start seeing effects. And when medication is finally given, you need to wait at least 4 weeks before you note an effect. And if you don't note an effect, at your primary care, you can let them know and they can either increase the dose or alter the drug or even add a drug in. So patience. When people have mixed urinary incontinence, stress and urge, we need to find out which one is the most bothersome and treat that first. And if the person deserves a surgery, we need to treat the urge incontinence first before tackling any surgical options for stress incontinence. Can I ask everybody to mute themselves, please, if that's okay? Right. So from your family physician, general practitioner, when is it that you will get referred onwards for care? Don't panic if you are not getting better with all of these. It just means something more needs to be done. If there's blood in the urine, sorry, can I ask that everybody mute themselves, please?
Sorry, Missy. Everyone is muted.
Okay, right.
There is a sound in the background. We'll look into it.
Yeah, thank you so much. So, red flags, what can be the red flags? Red flags would include blood in the urine, recurrent infections that are not proven. Those would all be red flags, okay? Now, those will warrant us looking out for things for cancer that might be responsible for this. And these are other red flags these are other indications for referral. Once you get to the tertiary center, they might want to do more tests. One of the important tests is a urodynamic study that will tell us what your bladder is doing, tell us what the sphincter is doing. Okay. Right. Sometimes people are struggling with these pelvic floor exercises and not quite getting it right. So we might refer them onwards to the physiotherapist to help with that, to make sure they are contracting the right muscles. And they might even help with some stimulators to make sure it is those muscles that are being contracted appropriately. They might also give them adjuncts, maybe pessaries or cones, to help with that. And then we can have some biofeedback as well. Whilst we're trying to get you sorted, there may be continence devices that can be offered. Some of them are pads to keep one dry, and some of them actually stop with the emission of urine. I've put some here. Basically, what they help do is they can either be put in the vagina to help lift it up and reduce the pelvic floor laxity, and the person becomes dry. Less commonly, there are things that are used to cover the urethra itself to help the person stop leaking intermittently. So not a pad, just put over that. And less commonly, once again, putting something in the urethra to stop it, and that has to be removed each time the person wees. People struggle with getting pads and diapers. So it's important to know that the continence care team in some areas is available to help with the supply. I'm going to gloss over possible options for surgery, but I want to emphasize on prevention, what you can do before you get to the GP and after the GP. But if all these fail, then there are surgeries. So it doesn't mean that nothing can be done. This is what we call a bulking agent. So that pelvic floor, if it's lax around the sphincter, we inject a colloid, like a gel, there so that it can reduce how wide the sphincter is, how wide the urethra is. And that just helps the person be dry. It's quite good in elderly people, people who are still childbearing, and it's done under a local anesthetic. More invasive options would include trying to make that pelvic floor tighter with different ways. You can use different options. Some people will need a false sphincter. Remember, I said the sphincter is the muscle that keeps people dry. Some people will need a device that will work as a sphincter, which will now surround the urethra, and the patient can control it. So all they need to do is press a button, which we put in the labium, and that moves fluid between both sides so that it kind of encircles the sphincter, keeping it dry. When they want to wee, they release the fluid. So that is also possible in specific indications. This is basically a summary of what the surgeries do, most of them, for stress incontinence. They lift up the pelvic wall. This is what it was, and they lift it up. Right. When it's urge incontinence, it's a bit different because here it's the bladder that's contracting a lot. So the person will have had the urodynamic study to see what the bladder is doing. When it's confirmed that it's an overactive bladder, we can give Botox. I'm sure a lot of people would have heard of Botox for facial procedures, but it works the same way. It is relaxing muscle. So it's relaxing the bladder muscle and then that helps the person hold urine for longer and not leak so much. For some who have overflow incontinence or they are not emptying their bladder adequately, they might need a catheter, and that's just the truth. That might be what they need. Some people are taught how to pass the catheter themselves. If they have good hand coordination, they can see and they can manage it. Now, I am going to summarize by saying, don't struggle at home. No, it's not a taboo. It is treatable. A lot of lifestyle modification comes into play, which you can do yourself. Bladder irritants, we've mentioned quite a few. Identify which one of them you are probably using quite a lot and stop taking them. Stop smoking. If it's recreational substances, withdraw them. If it's alcohol, which is a diuretic, reduce that or stop it. Don't always think it's an infection when you're leaking. There might be other causes. Seek for help. And I've mentioned that sometimes it's a symptom of an underlying problem. So you need to be sure that you're not dealing with something else as well. Okay? And let's all remain happy. Let's remain dry. And let's remain confident together. Thank you.
Thank you so very much, Ijeoma. That was a whistle-stop tour of a lot of information, and we're very grateful. I, for one, have learned a lot of things which I wasn't privy to before. We're waiting for questions, but by way of summary, I mean, you gave us some very useful anatomy. I finally appreciate the proper relationship between the anal canal, the vaginal tract, and the urethra and bladder, and how some of these can influence incontinence. That was very useful. Thank you very much. And also, you spoke about the different types of incontinence, mainly stress incontinence and urge incontinence. And you also spoke about what we can do about it. In every one of these talks that I've moderated, diet always comes up. So that's something that we must look for. You somehow didn't mention anything about exercise. Well, you spoke about pelvic exercises, but what about general fitness? Does that make a difference
It
to,
does. So it was on the slides, but yes, I didn't vocalize it.
yeah,
So I think I had a beautiful lady who was jogging and she had her monitor on. So it was fitness, getting your weight under control, taking charge. So yes, that is quite important, especially with the stress urinary incontinence,
yes.
because obesity in itself can be the only reason, and that is totally modifiable.
Yes, you also spoke about lifestyle, which again comes back to very much the same thing. I think the
Exactly.
more we look after ourselves as individuals and as a people, the better health outcomes that we're going to have. And the thing that you mentioned that surprised me a little was the increasing incidence of ketamine on the streets and how that is influencing incontinence in young people. So maybe we all want to befriend our children a bit better and find out exactly what they're doing. One of the things that I always realize when we do these things is that health is really, really, really interconnected with almost all other aspects of our lives. The one thing I've always wanted to ask, and I ask this of most medical practitioners, you get different answers. BMI. Some people say that the whole BMI concept was constructed on the white model, and that for Black people, it should be different from for us, so that we should be looking at higher BMIs as an indicator of health. What's your take on that?
So I would say that for most studies, not just BMI, for most studies, you need numbers to get power. So for you to make a statistical conclusion, you need to have adequate number of subjects that you've studied so that your conclusion will be well powered. Now, for us as Blacks to have data that is geared towards us, then there have to be that number of studies or mixed population studied, and then we can definitively say that there's a difference. But when we don't have that, we have the information available, and the information available is based on maybe predominantly Caucasian, maybe mixed populations, but it's the information available with adequate numbers that is well powered. The beauty about the BMI is that it does weight for height. The beauty about the BMI is that that in itself helps correct for body proportions. Yes, of course, it will not correct for a high density bone mass. It won't correct for that. But there are other adjuncts. For example, we measure the waist circumference and things like that. But I would still tell people, avoid a false sense of security by saying the evidence available obviously doesn't match me because it might have been done in a different population. For now, that is the available information and the available guide.
Okay. Okay. The other thing that occurred to me as I heard you speak is just to ask, is urinary incontinence an inevitable stage of aging? Is it part of the aging process?
I would say
Like,
aging increases the risk,
mm-hmm.
but you still have a lot of elderly people who are dry. So
Yeah.
it doesn't make it, the fact that you have every birthday doesn't mean that with every birthday you're expecting incontinence.
Okay. 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 And you spoke about pregnancy and the possibility of, well, pregnancy itself leading to laxity of the pelvic floor and also the possibilities for fistulae and all of that. How common is this?
Okay.
So is it the case that everybody who's pregnant should expect some urinary incontinence afterwards, either acute or chronic? Or is it the case that the more pregnant you are,
Sorry, I've lost you.
yes. Can
Okay.
you hear me?
Yes, I can hear you.
Yes, somehow there was a call coming. Right. Okay, I'm back. Or is it the case that the more pregnancies you get, or you have, not get, sorry, you have, the more you should expect urinary incontinence going forward?
Right. So there's a distinction, a fine line. So I think what I was driving at is that pregnancy increases the weight on the pelvic floor.
Yes.
So that can increase the person's tendency to have stress, urinary incontinence as the baby grows bigger. So during pregnancy, some ladies will describe that they leak urine when they laugh or cough because that increases the pressure on the pelvic floor. Once again, not everybody gets it, but those are known risk factors. Now, the labor part is different. The labor part is that they are having a vaginal delivery. During a vaginal delivery, the lady has to increase her abdominal pressure to push the baby out. That in itself stresses on the ligaments that keep the pelvic floor intact and causes some laxity. Sometimes some people need to have an assisted vaginal delivery, either with forceps, vacuum, or some cuts to help the baby come out. Those are additional risk factors for affecting the pelvic floor and increasing the risk of stress urinary incontinence. Once again, it's not absolute that everybody who's delivered will have it. Once again, we emphasize prevention. If you note that people with supervised pregnancies are taught pelvic floor muscle exercises, which they are advised to start during pregnancy to reduce their risk, and following delivery, they're advised to continue it. All of those are preventive measures so that we don't have the incontinence.
Okay. Okay. Thank you very much. Now, some very specific questions that have come. It says, which type of incontinence is the one? I'll put them all together so that maybe you can have a look at them. Which type of incontinence is the one when having sex? And the second one says, I'm very interested in one estrogen. From what age does it significantly drop? If I'm accompanied by a doctor, can I ask for it? And the third question is, how is prolonged labor modifiable? And the fourth one goes back to BMI. It says, my BMI says I'm obese, but my visceral fat is excellent.
Okay.
And it says in brackets 5. Should I worry? I didn't want it to affect my bladder.
Okay. Okay. I wasn't jotting those down, but I'll repeat them as I remember them. So there's, in one of the slides, I put incontinence during certain situations.
Yes.
So during sexual intercourse is one of the known things. Some during exercise. There's a specific type known as giggle incontinence. So there are some during specific situations. Once you identify what it is, then you can try to modify it. During exercise, there's something we call a NAC technique for pelvic floor muscle exercises. So if you have already identified that you leak when you're doing a squat or picking up things during exercise, then they've advised that get into the habit of doing your pelvic floor exercise and holding the phase when you're contracting them before you do that particular, maybe the squat or something, so that you've strengthened your pelvic floor during that particular thing that you've identified as a trigger. So that's helpful. For someone who leaks during sex, it means that you just need to intensify your pelvic floor muscle exercises and try to get that under and try to strengthen it. Some people specifically leak during an orgasm. Sometimes that might not be modifiable, but at least they've identified that it's only then that they leak and other times they are dry.
Okay. And then there was one about estrogen. From what age does it significantly drop?
So perimenopausal people, unfortunately, menopause varies from person to person. We have people over 40 who are around menopause, and we have people who take a while longer before they get to menopause. We also have the rare cohort of people who in their 30s are already menopausal. So menopause is individualized. One can suspect they are getting into menopause if their menstrual cycle starts becoming irregular, they start having hot flushes. Those increase the suspicion. then of course, by the time you confirm it by your hormone profile that shows that estrogen's lower down there, then one can benefit from estrogen supplementation. This comes in patches, comes as topical applications, comes as pessaries, which one can insert into the vagina. For recurrent urinary tract infections in an elderly person or a postmenopausal person, remember, I'm not linking the age in this case when I'm saying postmenopausal. So whenever that person attains their menopause, estrogen, what it does is it makes the area around the vulva, the vagina, more supple. It restores the normal epithelial lining. That makes it, keeps urinary tract infections at bay. But the fact that it's also reducing the shrinkage means that those that were having labial adhesions, they were having urethral narrowing, that was affecting how they urinate, that's all sorted. So I wouldn't put it as a specific age from which you will start looking for it. Look at the symptoms, look at what's going on, and then request for it. You can't get it over the counter without a prescription.
Okay. How is prolonged labor modifiable?
So my emphasis from the take home was have supervised pregnancies. Okay. Prolonged labor should not be an issue if the antenatal and natal period are supervised. Prenatally, they would have identified there is fetopelvic, there is disproportion between the baby and the pelvis, so they will know that this is a high-risk pregnancy for delivery, and they would have planned an elective cesarean probably. If it's a supervised delivery, by the time they realize that the delivery is not progressing, they would have done an elective cesarean. They would have done an emergency cesarean section. So that way they don't have, I don't know if you remember the baby that I showed pressing on the person's bladder, and yes, the bladder is, the pubic bone is pressing on the other end. So if they're in prolonged labor, it means that that is happening for so long. And eventually what happens is that the baby's head and the pubic bone have cut off the blood supply to that area. So eventually it will slough off. So when somebody has had prolonged labor, if it was in a supervised setting, they would put a catheter for a short time so that it allows the bladder to heal before the person starts using it to wee. So that reduces their risk of having a fistula. So that's why I say it's modifiable. It really shouldn't be happening.
Okay. Now, this is the one about BMI. It says BMI says she's obese, but her visceral fat is excellent, 5. Should she worry? She doesn't want it to affect her bladder.
Right. When we say obese, that means the BMI is above 30. Mm-hmm. I'm not sure what visual fat means, or virtual. Virtual, is it virtual?
No, visceral, sorry.
Visceral fat. Oh, yeah. Right, fine. So sorry, that's more truncal. Okay, that's more truncal. Do your waist circumference as well. We generally support both of, we use multiple things, but I think the BMI is usually quite helpful. I don't want to be very definite, but usually don't go above 30. Okay. It affects multiple other things, not just the bladder, because it's also telling us about other things as well. Okay. Increased risk for diabetes.
Oh, sorry. You're not finished.
Sorry, I was just saying increased risk for diabetes, increased risk for heart problems, hypertension. So they all go together.
Okay.
Yeah.
Is it possible for stress incontinence to occur only during exercise, but not with coughing, laughing, or sneezing in a physically active, nulliparous elderly woman? That's quite a precise question.
Yes, I think we've touched on that as situational. Mm-hmm. So it just means even though you're physically active, we now have to work on just strengthening the pelvic floor muscles.
Okay.
It is
so the short answer to that is yes.
Yes.
Okay. Right. I heard someone whose bladder gets overactive after eating oranges or clementines.
Okay.
Is this common? Is there prophylactic medication one can take to prevent it?
The beautiful thing is that people have identified triggers. So when I was talking about avoid bladder irritants, citric containing juices or fruits, for some people, that is their identified irritant. And when they withdraw it, it's fine. So just know what your body does, know what your body likes.
Okay. Now, this next question opens up a very wide area for discussion and perhaps something for another day, but maybe you could just touch on it. What about men, please? Some get incontinence after prostate cancer surgery or treatment.
Yes, we call that post-prostatectomy incontinence. So with prostate cancer surgery, what I had some lovely pictures in my last talk about the anatomy of the male pelvis and treatment for prostate cancer. We take out the prostate itself, things around the prostate, and the urethra passes through that prostate. And just underneath that area, we have the sphincter in the man. So all those can be affected with the surgery when we take out the prostate. However, once again, we emphasize pelvic floor muscle exercises. A lot of that incontinence is self-limiting, so that by the end of the year, the stress incontinence has reduced significantly, such that there might be only 1 to 2 leaks in a day, and they are really small leaks. Some people have permanent urinary incontinence, even though they have done all their exercises. In that case, I don't know if you recall the sphincter that I showed, which can be used in some women with neurologic problems. We can use it in men. In fact,
Yes.
it's more often used in men, really. So that sphincter can be used to stop them from being incontinent. The button where they press will be in their scrotum, and they just press it to release it so that they can wee. Now, other prostate cancer treatments, radiotherapy, can also cause incontinence, but in this case, it's irritation of the bladder that is causing the incontinence. In that case, we will make sure that it's not a secondary bladder cancer, and it's just because of the radiation. And then we give medication to help the bladder relax a bit.
Okay. How do you deal with urinary incontinence in an older person who has had strokes or a stroke?
Okay, so that's where the neurological part comes in. So the bladder is controlled by nerves. The nerves pass from the brain through the spinal cord and then come to the bladder. And then when the bladder fills, nerves go through that all the way. So it can be disrupted when patients have strokes, Parkinson's disease, learning disability, cognitive dysfunction. We look for what the symptom is. Sometimes it is just that their bladder is contracting quite a lot, and we can give something for that. Sometimes it is that they are not emptying, so they are leaking because of an overflow, in which case, if they can, many people who have a stroke might not be able to do this, but if they can self-catheterize themselves. They can pass a catheter themselves and drain it off once or twice a day. For those who can't, some of them might need an indwelling catheter. So we basically look for the effect, what is causing it, and see what we can correct. In some of those patients, they will need that urodynamic studies to give us more information, and then we work with it. Some of them might need some Botox to help with that, but it just depends on what it is. And of course, anything correctable neurologically, the primary cause, it's worth correcting those.
Okay.
For those with Parkinson's disease, they are on medication for it.
Okay. Thank you. Thank you very much. Very, very impressive responses. Now, a couple more, and then hopefully we'll wrap up unless something else stands up. At what age should children be dry at night? As in excessively wet at night, their output far exceeds the input. Thank you.
Okay. So we don't talk about children being bedwetters or being incontinent or having what you commonly see your letters say, maybe nocturnal enuresis. It's just bedwetting. We don't talk about that until they have been potty trained. And most children are potty trained from 5. So we definitely need to first confirm that the child has been potty trained. And if it's continuing after that, then we can be looking into it. There are different types of nocturnal, of bedwetting. Some people never became dry even after they achieved the age of bedwetting. Some achieved the age of bedwetting and somehow they've reverted to becoming bedwetters. There are different causes for each. So that's the age question. I don't know if there was a second question about what to do in terms of output being more than input.
Was
that
no, it was just part of the presentation that in this case the out far exceeds the input.
Fine. There are simple things that can be done. For example, a lot of times you find when you actually look at when the child is drinking, even though they are drinking small amounts, the common thing is they won't drink in the day, especially if they are going to school, and when they come back, they drink loads of stuff. So avoid them drinking late into the night if they are bedwetters. Avoid giving them bladder irritants, so the Coke and the soda and Coke, avoid it at night. Because even though it's a small amount, it might precipitate leaks if they have that.
Okay.
There are so many other reasons. I will not go into that, but I'm happy to discuss them afterwards if required.
And finally, I think, I'm not too sure how applicable this is, but how do you live with urinary incontinence at 30?
Okay. So the whole essence of this talk is get help.
Yeah.
You probably don't need to live with it and manage your symptoms. Get help and get it sorted. Okay.
Okay.
But remember, a lot of the power lies with you in terms of what you can do, but get help and do all those other things as well.
Okay. Dr. Ijeoma, thank you ever so very much. Thank you.
Thank you.
I thank you personally, and I also thank you on behalf of the broader community. This has been illuminating. This has been, I started by saying that we are going to get an education, and I think that is exactly what we've got. Your answers were properly fleshed out, and they gave a lot more information than I thought we were going to get. We're very grateful for your presence this morning, and we look forward to further engagement, further interaction. Perhaps one day you might humor the men and do something similar for us as well. We'll
happy to do so.
Right. We've come to the end of our talk for today. Viewers, everybody who's joined, please remember that on YouTube, we have a whole library of all the previous talks that we've given. And we've been doing this for at least, well, about 5 years, COVID time. So anything that you think about that you would like to hear about, please look on YouTube. And more than likely, you'll find that there's been a CAHN, a CATHIP talk in the past. So please look for that. If you have any further input, any questions or yes, any questions or any inquiries, please, you can contact us at email address health@cahn.org.uk, and there'll be somebody who will respond to you and take your inquiries further. So please keep in touch. At this stage, I will, well, once again, say a very big thank you to Ijeoma, and I will hand over to Wisdom, who will close this event for us. Thank you very much, everyone.
Can you hear me? Can everybody hear me?
Yes, we can. I can hear you. Yes.
Okay. Yeah. Thank you so much. Thank you so much, Michael, for hosting, and thank you so much, Ijeoma, for the valuable information you shared. I've really learned a lot, and yeah, I'm someone who is we really like fizzy drinks a lot. So yeah, I've really learned a lot of how to go about it. Yeah. So just not to take much of your time, we would like to share information about the services CAHN render. And same time next week, Health Hour will return, and the topic will be thriving through menopause, essential tips to stay cool and confident. which our guest speaker is Dr. Joyce Ame. So move to our next is the Black Health Awards, which will be live in July. We had our first one was held last year in London. That was Park Plaza, Westminster Bridge. That's London. So it will still be the same venue this year. And also, nomination is open. So if you have anyone in mind that you'd like to nominate, kindly scan the the QR code or click on the link to nominate. Yeah, and then we have the legal drop-in session. So this is more for helping people or having knowledge about the breakdowns of wills as a power of attorney. So this is a webinar session that will be held on the 27th of March. So you could join the Zoom link to have more information about this wonderful session. So we have the strengthening families. That's a generational approach to domestic abuse. So this will be on this coming Friday, 28th of March. That's 5 p.m. That takes part like in online discussions, a webinar discussion that to talk more, to learn practical ways to support others, engage and with experts and live experience, ask questions in a safe space. So don't miss out. Kindly scan the QR code to learn more and secure a spot today. Also, finally, we have Green and Arts Wellbeing. So this is one of the services we render through making sure our mental well-being is in good shape, like involving ourselves in activities like painting, nature walks, and more. So this is every Wednesday at Bolton, and then we have one that's in Stockport every Tuesday. So yeah, come around, come and have fun out and make new friends. For any inquiries, you can contact Lola, one of our colleagues at greenartswellbeing@CAHN.org.uk for more information. Thank you so much for joining us today, and we hope to see you all next week as we have a very interesting topic next week. So looking forward to see you all. Enjoy your weekend and see you next week. Bye.
Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National